This program is a presentation of UCTV for educational and non-commercial use only.
Welcome to the University of California, Davis Health System. Since 1973, continuing medical education, CME, has been an integral part of the educational mission of the UC Davis School of Medicine and Medical Center. The Center for Health and Technology, CHT, increases access to health education and promotes interaction between patients, physicians, and other healthcare professionals through the use of telecommunications and computer technology.
It's a pleasure today to present this discussion on Look Behind the Mask of Depression. What I'd like to do at this point is to give you my affiliations and disclosures. As I noted already, I'm with the UC Davis Medical Group. I also am a member of the Neuroscience Education Institute through UC San Diego, and Dr. Stephen Stahl, who was very generous in allowing me to use a number of the slides in this presentation with permission. And I'm also a speaker for Forest Laboratories and AstraZeneca Pharmaceuticals. The agenda and objectives today are fairly straightforward. I want to identify the issues behind the mask of depression and discuss with you a primary care psychiatry algorithm that I have developed over the past 8 years. What I'd like to have you be able to do is differentiate and understand the basics of this algorithm so that you too can differentiate primary anxiety disorders from primary depressive disorders, identify the 5 primary anxiety disorders, and differentiate bipolar versus unipolar depression, as well as bipolar disorder versus ADHD. If this seems like a lot to do in a 15-minute office interview, this algorithm will help you develop this. While you're looking at this slide for a moment, hidden in plain view, to find the man, let me back up for a moment and give you a little bit of background as to why I've developed this algorithm and some general concepts in psychiatry and psychopharmacology, especially in the primary care setting. As I've mentioned, I've been spending a considerable amount of time in the last 14 years with UC Davis in primary care psychiatry. And it's a distinct pleasure for me to be able to develop and discuss this algorithm with you now in more detail. I developed the algorithm initially as a way of better finding bipolar patients in my practice and new patients that would present to me. But over the past several years, what I've come to find is that this algorithm has expanded well beyond that initial plan, so that I have been able to learn and teach this algorithm to many providers so that they too can find their bipolar patients as they walk in the door. And the best part of all of this is that this can be done often in a single 15-minute office interview. This is probably the most simple, time-conserving technique and tool that I've been able to utilize in all my primary care psychiatry. I've had a special interest in bipolar disorder, a fascination with this condition. I've seen so many damaging and toxic effects of this condition on patients and their family members. At the same time, I've been able to share in the joy of helping patients and their families as we heal and mend the issues of bipolar disorder. Bipolar tends to create hatred, fear, worry, and this is what recognizing this condition will do. It will help alleviate these kind of issues. In order to control the beast, as I say in many of my lectures, you first have to find it. And as it turns out, bipolar disorder is the #1 missed psychiatric disorder in this country today, despite the fact that we spend so much time in classrooms and in conferences. trying to find these patients, make the diagnosis, and then treat them. These patients are often what I call hidden in plain view within our own practices. And that's why the man in the coffee beans, to see if you could find this particular man and head. This is part of learning how to find somebody that is hidden within your practice, looking for patterns. Bipolar patients typically present with the plethora of physical, emotional, and social problems. The typical emotional complaints are that of depression and anxiety. The difficulty is that this is what most of your other psychiatric patients will also present with, depression and anxiety. This becomes the greatest barrier to finding the bipolar disorder patients. We all share in the problem and concept that time is of the essence. We do not have the luxury of a comprehensive psychiatric history during a 15 to 20-minute office interview. So what we need to do is distill down all of the issues and problems to the essence of the condition, which I call the core feature. And we could recognize this frequently within minutes. The basis of my algorithm, then, is to deal in the concept that less is more. For every 100 patients that you have that are considered depressed in your practice, the average would be 20 to 30 that are statistically, in fact, bipolar. How many of you in the audience today would consider this fact as part of your own practice? These numbers are well validated nationally. Physicians often have said to me in many of the travels that I've done, I don't treat bipolar disorder. The fact is, if you don't recognize the condition, then you are missing the condition and not treating them properly. But you still are treating bipolar disorder, unfortunately not optimally. In psychiatry, we do not have the luxury of biologic markers as we do in medicine for many of the disorders, such as heart disease, diabetes, cancer. We must make our diagnoses the old-fashioned way. That is, by listening to the patient, interacting with them in our office, and watching their behaviors. With regular practice, this algorithm, which we'll go into here in just a moment, can be used as a guide with signposts to deal with your psychiatric patients and others that you're not certain of the diagnosis. It can help you frequently and lead you in minutes to a definitive and correct diagnosis. And finally, remember that once you have made the most likely psychiatric diagnosis, bipolar or not, you are still not done. The challenge remains that most psychiatric disorders, and especially bipolar, have multiple comorbid disorders. This includes other psychiatric disorders, possible personality disorders, substance abuse, sleep disorders. If you have patients that tend to smoke or drink too much, consider a psychiatric disorder underlying this condition. And if you have patients that have persistent depressive and anxiety type symptoms, despite the fact that you feel that you've treated them very well, look behind the mask of depression. Look behind this appearance, because this is the topic that we want to discuss today. Look behind the mask of depression, for what is hidden there may really provide the real answers. So let's begin now and delve into the topic and look further. By the way, we'll go back for just a minute here on this slide, and the man in the coffee beans is right here. The forehead, the nose, the eyes. So you've had a chance to look. Now that you've seen this pattern once, if you were to look at this again, whether it be in a month or a year, you would probably recognize this face very quickly. As with bipolar, once you start to recognize the condition, even once or twice, from then on, the condition starts to jump out at you frequently. So let's move into our office setting now and see a typical patient who walks in with this kind of condition. How are you feeling? How's work? How are you doing with exercise? How are the holidays? Mixed in with, I have a sore throat, I have problems with my eyes, my weight, my back. As primary care providers, we need to construct a diagnosis from all of these symptoms. And once we construct a diagnosis from there, we tend to deconstruct back down to the symptoms and then treat those symptoms. Let's look. We often think of the difficulty in doing this, but look how easy it can be. If I say to you as a 40-year-old man, I feel like I have an elephant sitting on my chest, despite all the other issues that I brought up, you know immediately you're looking at a cardiac condition. At least that would be the top of your list. And if I said I had a severe headache with stiff neck, you would think meningitis, and you would want to rule that out before looking at anything else. In fact, with a cardiac status, if it is truly an MI, you know who to call, what to do, not only now, but for the weeks, months, and years ahead, in fact, for the rest of the patient's life. What are the verbal clues, though, if you're looking at psychiatric disorders? Unipolar depression, anxiety disorders, bipolar disorder, ADHD, that's attention deficit hyperactivity disorder. Do you have clues in your mind that if you hear something, you'll think immediately, this may be a psychiatric disorder? When I'm in front of an audience, I tend to ask many of the participants, but since I don't have that ability here, let me give you one or two clues for each, and then I'm sure you can continue to develop many more ideas yourself. For unipolar depression, one of the common symptoms is fatigue. If you do not have underlying heart disease, thyroid disorder, cancer, the biggest factor for unipolar depression is fatigue. Anxiety disorders, worry, and multiple physical complaints. Bipolar disorder is mood lability. And ADHD, I try and fail. So there are a number of other symptoms and complaints that we'll talk about during the session here today. The other, since you have a patient looking at you and you're watching their face, you can use benefit of body language and facial expression. It's easy to see in here when you look at faces how different they are, and they are often a clue to what we are thinking in our own minds. This child obviously is sad. Here we have a seductive young lady. Here's someone angry. Look at the body language in the face here of someone that's dejected. When someone has a finger in front of their mouth, often they're lying, or the tongue protruding may be lying. And this here, surprise perhaps, here's surprise, and we often recognize faces even by just partial facial expression and nose and mouth. Who is this? That happens to be, up in this left-hand corner, President Clinton. But why do I have the Lone Ranger and Zorro in this? Again, we're looking at look behind the mask of depression. That's the whole purpose of this talk, so that I want you to look when patients are talking to you and they look depressed and crying. I want you to go further. Don't immediately jump to the conclusion we're looking at a patient with unipolar depression. You can't tell what these two people are thinking. Maybe you can, but in any case, you really have to delve further for history. So in primary care medicine, from the multiple physical and emotional complaints and symptoms, we construct a tentative diagnosis or syndrome. This is critical. We have to think along this direction, and then after constructing that tentative diagnosis, we deconstruct the syndrome back to symptoms and treat those symptoms. One other factor before we move into the actual algorithm, sleep and sleep disorder is such a helpful finding within psychiatry and primary care psychiatric patients. So think of psychiatry and sleep as synonymous. Sleep as a psychiatric vital sign. So if someone has difficulty falling asleep, often an anxiety disorder. Early morning awakening, unipolar depression. Awakening at midnight to 1 in the morning for an hour or two, often excessive alcohol in the evening. Hypersomnia when depressed, suggests bipolar depression. Lack of need for sleep for several days or even a week, that's fairly easy. Hypomania or mania of bipolar disorder. So again, a very neutral type of a question that leads to a great deal of information. Now back to the issue. Most of our patients, in fact almost all of those with psychiatric disorders or considerable stress, will present with a combination of anxiety and depression or depression and anxiety. And remember, it's very important to understand that when they have depression, it does not equal a depressive disorder. And when they have anxiety, it does not necessarily equate to an anxiety disorder. Why are we looking for the information quickly? And that's obvious. We don't have a lot of time. We need to get the information quickly to get to the core feature. And that's what we need to do in primary care medicine, as we've talked about already. This algorithm will work if you practice that. And let's start with step one. When these patients, whoever they are, typically adults that we're looking at, but even adolescents, present with an anxiety and depressive type of presentation, we want to differentiate, is this a primary anxiety disorder with depression or a primary depressive disorder with anxiety? And people often say, do I really care? Is it necessary? How about treating with an SSRI and see what plays out, and whatever results I get, then I could deal with the next step. But you really need a focused diagnosis to have focused treatment. Why? If you take an anxiety disorder, and we'll go through the 5 major ones in just a moment, if you treat with too high a level of your medication, let's say an SSRI, you will tend to make that anxiety disorder worse, and you often get intolerance to the medication. Patients stop the medication, and you have failure right off the bat. On a depressive disorder, you tend not to make the depression worse by starting with a dose of medication. So you can, in an anxiety disorder, start with a very low level of medication and get good tolerance. If you start too high, the tolerance is poor. Otherwise, with a depressive disorder, you can start your initial dose of medication fairly close to your therapeutic dose. If you have an anxiety disorder, you need to know which one. The counseling is different between anxiety and depressive disorders. The prognosis and long-term evaluation and treatment is different. So you need to be able to differentiate, and take OCD as an anxiety disorder. The ultimate final dose of an SSRI will most likely be much higher than the dose of medication used for a depressive disorder. And if you have a PTSD as an anxiety disorder, underlying depression, and you counsel for depression without understanding that that patient truly has a PTSD, you will never be able to really improve that patient's status. We also have the option of using a 9-symptom checklist. This is an easy way. I put this in so that you can take a look and see for screening. It's a 5 to 10 minute history that you can take as a routine screening of all your patients. But if you want to look at that first step again, and we go back for a moment, how can I differentiate the two? I differentiate them in a minute or less by just a brief amount of history. If the patient tends to worry about their anticipated future, you're dealing with an anxiety disorder. They worry about the kids, they worry about their job, they worry about their health in the future, they worry about most issues in life. And this is your anticipated future. It has not yet happened, and many times the things we worry about never do happen. But this is the core feature of an anxiety disorder. On the other hand, dwelling in the past, regrets about issues in the past and other issues that they've dealt with in the past, that's your depressive disorder. So in 1 minute or less, if you worry about your future, you have an anxiety disorder, and we'll discuss which one. If they dwell in the past, these patients tend to have a depressive disorder. Many patients will say, I have both, but I typically will say at that point, let's see which is the way that you normally look at life. So of the 5 primary anxiety disorders, we can go through those 5 fairly quickly. You need to memorize these, because these are the ones that as soon as you know that they have worry about the future, you ask, have you had panic reactions? Have you awakened in the middle of the night without any warning and gone to the emergency room, for example, and had chest pain or shortness of breath? This is your typical panic disorder that x-rays, EKGs, all the lab work is normal. They come back to your office, and they have these repetitive panic reactions for no apparent reason. Another social anxiety disorder, the fear of speaking before others, the person that wants to withdraw to the background. The general anxiety disorder, the patient that worries about everything, usually typically for 6 months or more. The obsessive compulsive disorder is this intolerance to uncertainty, the inability to feel satisfaction, the need for perfectionism. This tends to remain more hidden. Patients are often embarrassed about this. This occurs often early in life and can be very disabling. And post-traumatic stress disorder, which has a variety of system clusters: exposure, re-experiencing, hypervigilance, avoidance and numbing, hyperarousal. This all refers to something that happens traumatically in someone's life, physically or mentally, emotionally, that leaves a deep scar, and re-exposure or thinking about that episode will bring on all of the symptoms of the anxiety and depressive symptoms as if it was being experienced now. I leave this as a screen for you and as a slide to have as a routine PTSD screen rather than going through all of this now. But this is an excellent way of screening because OCD and PTSD are the two anxiety disorders that tend to remain most hidden behind that mask of depression and anxiety. Now we move into the area that I find very interesting, and that is being able to differentiate our bipolar patient from the unipolar depressive disorder. Because as we all know in primary care, when you feel good, you don't go see your doctor. Why would you? When patients feel elated and in that hypomanic state, they typically do not see their doctor. When do they go see their physician? When they're depressed, just like the patient with unipolar depression. So we really, in these kind of situations, truly have to look behind the mask of depression. We always have to think, is this depressed patient bipolar? Realize that not all depression is unipolar. In fact, about 20 to 30% is bipolar. And unipolar depression then becomes a diagnosis of exclusion. So who do I screen for bipolar? Basically everyone with a depressed mood, everyone who has a general anxiety disorder, those with behavioral problems, those with substance abuse, and what the FDA Health Advisory recommended, screened for bipolar disorder before initiating any antidepressant treatment. That's a fairly tall order, but extremely valuable. So what are the 4 signposts that I use that will give me an answer of bipolar disorder versus unipolar in about 7 or 8 minutes? The core feature, and that's the first signpost, of bipolar disorder is that of mood lability and irritability. It has an 86% specificity for bipolar disorder. This is the patient that says to you, I came in because I got depressed last Wednesday at 3 o'clock in the afternoon. I was feeling good in the morning, but suddenly got very irritable and angry and depressed. But I know it'll go away in a day or 2, maybe 3 or 4, maybe a week. And then I'll really feel good, I'll do well, but I know later I'm going to have to pay the price. And as soon as I hear pay the price, there's my trigger. And paying the price when you feel good means the higher you go, the better you feel, the more you're going to drop into depression again. And paying the price is the depression for the feeling good. Now the second signpost I call the rule of 3s so that you can remember that fairly easily. It represents dysfunction. 3 failed marriages, 3 failed jobs, and 3 failed trial of antidepressants. What we're saying here is that these people go through multiple relationships and jobs. They often not only lose jobs, but they're often fired or quit before they are fired in order to alleviate themselves of the stress or others to alleviate them of the personal interactions at that job. So these patients may in their early 20s even start working on their own because they cannot work with others. And they've often been tried on a multitude of antidepressants. As it turns out that they may work well, the SSRI, initially within the first few days or a week. But given 2 or 3 weeks, that antidepressant starts to cause more irritability and more problems for the patient. They often drop off that medication and may not even present back to you to discuss this. The third signpost, which I find to be extremely valuable, is the one that's missed by most primary care providers across the country. So if you're looking at this with me here today, you may well be one of these that take a great family history of the physical disorders, but what about the psychiatric issues? If you have bipolar disorder, you are going to see other family members, close family members with bipolar disorder, also schizophrenia, drug abuse, alcoholism, suicide, people in jail. You'll start writing as quickly as you can, because when you shake that family tree, the apple doesn't fall far from the tree. And if they have family history of bipolar, and sometimes thyroid disorder, the Hashimoto's, the autoimmune, falls into this category, you're going to need to think immediately, this could be a bipolar patient. And the early age of onset, often during adolescence, not in the late 20s as you see with unipolar. So these are patients that get angry and have irritability mood lability. They go into depression quickly, not over weeks to months. They have multiple loss of jobs and relationships. They've been on antidepressants and that have not worked. The family history is strongly positive for bipolar and other psychiatric disorders, as well as alcoholism, drug abuse, suicide, and jail. And they've started having their symptoms as early as typically 13 or 14. This is not your history of a unipolar depression patient. So as soon as you get these 4 signposts, you have your diagnosis right then and there. Now, you need to still fine-tune. You have to look for other comorbid illnesses, but you have your core features of bipolar disorder. And many that I have treated have had problems for 10, 20, and even 30 years before a 10-minute or 15-minute office visit leads to the correct diagnosis. I show you this that you can print out from online. This is called the Mood Disorder Questionnaire, developed by Robert Hirschfeld, and has been available and in offices for a number of years. I show this to you because if you screen all of your patients with depression and anxiety disorders, you'll find a certain percent will turn out positive for bipolar disorder. And let me go through that with you for a moment. The Positive Mood Disorder Questionnaire has question 1, 13 different parts, and if 7 of those 13 are positive, in a sense that mood lability, not needing sleep, impulsivity, and other issues that suggest a manic or hypomanic state. If those 7 of 13 are positive, you have leading toward a positive mood disorder questionnaire. If several of these occur simultaneously, that's another feature that helps confirm a diagnosis of bipolar disorder. And the third is how much disability is there, impairment. If there's moderate to severe, that along goes with the bipolar disorder. The mood disorder questionnaire is for the manic or hypomanic phase of bipolar, not the depressive phase. So if you take a patient that has depression and has a positive MDQ, you are most likely looking at a patient with bipolar disorder. Robert Hirschfeld, a number of years ago, sent out, and you can see up here, over 85,000 questionnaires across the country, and 3.7 screened positive for bipolar disorder. That fits in the typical statistics that have been validated over and over, that usually about 5% of the population with depression will have bipolar. Now, of those patients that sent back the questionnaires, 49% had neither a diagnosis of bipolar nor unipolar depression. Here, 31% diagnosed with unipolar depression or some other form, and only 20% were diagnosed correctly with bipolar. So looking at this, 80% of the patients who screened positive for bipolar disorder had not been diagnosed with that correct diagnosis. Another study, 649 outpatients receiving treatment for depression, and we look at this area, 21% screened positive for bipolar disorder. When they looked at these patients in greater detail, what they saw, if you look down at the bottom here, it says an MDQ sensitivity of 58%. That means 42% will be false negative. But look at the MDQ specificity of 93% right in here. That means if you have a patient that fills out this mood disorder questionnaire and it is positive, there is only a 7% false positive rate. So why the low sensitivity is that if patients fill out this mood disorder questionnaire themselves, they may well underestimate the problem and the severity. So it's best to validate the MDQ with somebody else either in the room or have them take their questionnaire home and have a family member fill that out and bring that back. But once you have a positive MDQ, there's only 7% false positive. That's the take-home message here. Use the MDQ, use the 4 signposts. Think about this anytime you see a depressed patient. And finally, Underrecognition in a general medicine clinic, patients screened with primary care, 1,100 patients, 10% screened positive for lifetime history of bipolar disorder. But depression, not bipolar, unipolar depression, was the most commonly diagnosed in 80% of these patients. So what happens in our bipolar patient? We look at a longitudinal assessment of bipolar disorder, and that's critical. When I ask about what is your life like, what has it been like, I look back, not a week, a month, a year. I'll ask very quickly What about your teenage years, the early 20s? Somewhere along the line, you're going to see episodes of depression. You'll see mania or hypomania. You'll see subsyndromal depression. You're going to see a varying form of mood lability. I'm going to talk to you in just a moment about the different forms of bipolar, because this tends to represent the types of patients we see in primary care medicine, which is known as the bipolar II disorder or bipolar NOS, not otherwise specified. This is not your typical course of a bipolar I, which we see in primary care very infrequently. What about age of onset? Look at the statistics here. When you look, this is the incidence of patients and when they have their bipolar disorder onset. And you can see by the age of 19, as much as 80 to 90% of our patients have already been either diagnosed or have at least had symptoms. Now, very often these patients are not diagnosed and their symptoms are missed. And now into the adult life, we have to pick up the pieces of these people that have lost jobs and families. That's often where I see them. What are some of the common comorbidities in bipolar? And they're all here. We've mentioned them already. So if you make a diagnosis of bipolar, your job is not done. What you need to do at that point is think, what other comorbid conditions are there? And there are lots. Anxiety disorders, drug and alcohol abuse. In fact, we say that the #1 treatment of bipolar disorder in this country today is Jim Beam, alcohol, because we are not picking up these patients and diagnosing them correctly. There may be psychosis, aggressiveness. Many of these patients end up in jail or in court at least. ADHD has about a 20 to 30% comorbidity. And borderline personality often seems to overlap with this. So once you've got the diagnosis or tentative diagnosis of bipolar, your job is certainly not done. Here's something that stands out immediately that is so critical. What you are not seeing along the side, these are relative morbidity and mortality ratios of looking at if you have untreated bipolar disorder in red as compared to treated, how do these patients relate versus patients that do not have any depressive disorder that we consider normal. Every condition, whether it be a physical or a mental condition, and especially suicide, is higher in terms of mortality rate versus the normal population. It's small with neoplasm and cardiovascular disease, so anything above the line means greater morbidity and mortality in patients with bipolar. So the red is untreated, the green is treated. But wait till you get to suicide. Untreated bipolar I disorder runs about 29% higher rate of suicide than the common normal population. Treated, it's about 6.4%. And this is bipolar I, major mania and major depressive disorder. Bipolar II is listed as hypomania and major depressive disorder. Because it's hypomania, people often think this is not as severe. I can get by, they can get by, there's no issue that needs the urgency of treatment. However, when you look at the statistics, the suicide rate in bipolar II is actually higher than in bipolar I because these patients go unrecognized in our practice, and when they go unrecognized, the impulsivity, usually during the mixed or depressive phase, leads to suicide. One other tool that I have used over the years and just keep in the back of my mind when I'm seeing patients, one you may recognize, the other may not, but think of the SIGI caps that you may have learned years ago. 2 weeks of duration of depressed mood, perhaps anhedonia, lack of enjoyment. Then the sleep disturbance, the interest, the guilt, the loss of energy, problem with concentration, changing appetite, physical complaints, suicidality. This is your SIGI caps mnemonic. How about for the manic or hypomanic phase? If I am manic and I'm out in my backyard with a shovel, I am digging fast. That's the mania, the hypomania. If it's 3 to 7 days, I tend to think more manic if it's severe. If it's hypomanic, it may be much more short-lived and milder symptoms. But the irritability, remember that I is irritability. That's the core feature, the mood lability and irritability in bipolar. Distractibility, insomnia, don't need sleep. Grandiosity, I know more than my teacher. I can invest and make millions. Flight of ideas, jumping from one topic to the other. activities, taking on multiple activities, but unfortunately, as the patients get worse, these activities fall by the wayside and they become very non-functional. Their speech is rapid and pressured, coming out of their mouth like bullets out of a machine gun. And the thoughtlessness is all the risk-taking behavior. The sexual indiscretions, the losing of jobs and families, maxing out credit cards when there's no money in the bank. So if you think Siggy Caps for depression, I Dig Fast for manic or hypomanic symptoms, and you utilize these two mnemonics in the room with the patient over and over, you'll start to be able to pick out the depressive and hypomanic or manic symptoms, especially the hypomania, because that's what tends to remain hidden. They may not be presenting with hypomania at the time, frequently not. They may be able to think back and give you those symptoms, but they're often having thought-dependent thinking, which means they don't think about the past. They only think of what's a problem right now. So I mentioned already bipolar 1, major manic symptoms and major depressive disorder. Bipolar 2, hypomania, milder manic symptoms, and that's why we say hypomania, and usually lasting anywhere from a day or two. And cyclothymia, another form of the spectrum in which patients have mild subsyndromal depression and mild, frequently, hypomanic symptoms. And these are the labile moods that patients have, these eggshell personalities. So seeing somebody that is changing mood frequently, not severely, it could well fall into the bipolar spectrum. And patients with cyclothymia as well as dysthymia tend to have a higher incidence of unipolar and bipolar depression. And then the bipolar NOS, which tends to be irritability with major depressive disorder. You can see the coding at the bottom. Mixed episodes can occur in bipolar 1 and 2, it's now recognized, which means that you can actually be very irritable and hypomanic and also depressed simultaneously. These patients are at higher risk for illness and especially suicide. So when we try to compare, and I leave this slide up for you, we don't have to go through every single item on here, but you can often differentiate between bipolar and unipolar by their history. One of the things to note is the early age of onset with bipolar, often in the early teenage years, 13 or 14, when the sex steroids kick in, and for unipolar depression, often the late 20s. The other seasonality, and the other postpartum depression, think possible bipolar disorder, much higher incidence in the bipolar to have severe postpartum bipolar depression. And these patients are at risk, not only to themselves, but to their babies. The final step in this algorithm is to differentiate bipolar disorder versus ADHD or both. And why do we need to do this? Because the treatment of ADHD is stimulant medication, and if we use that stimulant medication to treat our bipolar disorder, we may ultimately make that bipolar disorder patient more unstable. And when you give stimulants to a patient with bipolar disorder, you can create a manic or hypomanic state that causes the patient to become flighty, to become dangerous, to become very destabilized. So remember, the bipolar disorder patient's core feature is bipolar affective disorder, which means it's a mood disorder. This is usually recognized in adolescence or later, but typically 13, 14, 15 is when we have the symptoms begin. In ADHD, the core feature is a cognitive disorder affecting focus, concentration, perhaps memory, usually begins in childhood and recognized by the age of 6 or 7. So again, you've got a big difference. Age onset, types of core features. Bipolar affective, core feature, affective. ADHD, cognitive. Now, ADHD is really a bit of a misnomer because it's not truly attention deficit hyperactivity disorder, and this is what fools many physicians. A deficit means it's problem with attention. This is really attention inconsistency, because you know of children and adolescents that when they're interested in the computer games and in all the other things that are exciting to them, perhaps motorcycles, what happens is they focus very well. It's the dry, boring stuff, the things that you have to learn in school every day. These cognitive disorders affect the focus in the dry problems of basic learning. Now, depends on what you're studying. If you enjoy what you're studying, it's not an issue. But when children are at 7 and 8 and having problems keeping up with their peers, they often start getting anxious and they start getting depressed, even in the 9-10 year age group. From there, they may get into substance abuse, typically marijuana in the early teenage years, and that continues often, which is unfortunately because it causes lack of focus as well. And there's oppositional defiant disorder frequently. There can be also other disorders of conduct, stealing, lying, fire setting. When you look at patients that have mood lability, cognitive problems, problem with focus and concentration, they're out of control, the parents are having frustration, you have to look back to the core feature and unwind and peel off that onion layer by layer to see what the core feature is. If at the center of the onion it is a problem with affect and that started in the early teenage years, you're looking most likely at bipolar. If it started at 7 or 8 years of age and the core feature is cognitive and learning, you're dealing with ADHD. But remember, there is about a 20 to 30% overlap between these two disorders. So you may see both. Now, when we think of ADHD, we often think of children, and once they leave childhood, we think that ADHD no longer exists. But if we run into about 5 to 10% of the children who have ADHD, at least half of them continue on into adulthood with either cognitive problems or social problems or both. And this does interfere and does create additional mood disorders. So let's look for every 10 adult patients you see with a mood disorder, at least one of them also has ADHD. For every 10 adults for whom ADHD is diagnosed first, 4 also have a mood disorder. For every 10 adults in whom ADHD is diagnosed first, 5 also have an anxiety disorder. What is the impact of development on ADHD? And this is important because we need to look from early childhood. We don't have to spend long periods of time, hours, going over the history of ADHD, but certain things start to bear out very quickly. Inattention starts at around 4, 5, 6. We have working memory. We have memory that needs to stay and remain a sustained attention in order to listen and deal with others, to learn in school. But take a look at the upper slide. We have inattention that increases quickly and persists often throughout life because ADHD has a condition that affects the frontal lobe as well as deeper areas of the brain, certain receptors of dopamine that are with us on a genetic basis, and this tendency does not go away in most people as they become adults. And you can see this as we move out to adulthood. But impulsivity may drop and hyperactivity may drop, and many young girls do not show hyperactivity at all. In fact, they sit very quietly as their mind wanders. And then, finally, comorbidity. These are the problems with drug and substance abuse, the problems with the law, the problems with marriages and jobs that just don't work out. And the key feature that patients often say, I tried and failed. Now, let's take a look here and see how this plays out. Preschool, that's when we start looking at the issue of inattentiveness. Obviously, comorbidity is going to be very low. And we look at the school age, where we look at impulsivity and hyperactivity. But as we get older and the frontal lobe of our brain develops stronger, the impulsivity and hyperactivity is brought under better control. But when we get into adulthood, with the inattentiveness and the impulsivity, we start seeing much more comorbidity. So need to be aware that anybody who presents to you with depression or anxiety or substance abuse has to be screened not only for bipolar disorder, but for ADHD as well. So what are the comorbidities? We've talked about that already. Major depressive disorder, because I've not been doing well even though I've tried. That's the issue of major depression with ADHD, 10%, dysthymia, 20%. But look at the increase at bipolar disorder, 20 to 30% comorbidity. This becomes one of the major difficulties differentiating the two. There's a general rule of thumb, however. if you're going to deal with a cognitive disorder as well as an affective disorder, always treat the mood disorder first. Get the mood disorder under control, and then treat the cognitive portion of the disorder. And that's a basic rule when you're looking especially at a condition like bipolar and ADHD. Very often, treating the affective disorder will allow the cognitive disorder to improve, and that's what we hope for. Then we look at anxiety disorders at 10%, alcohol dependence, and then drug dependence we see also. So coming back to the features again of the algorithm, here's where we need to go back and think back of the lecture that we've had, this discussion, and say, when I see this next patient that comes into my office, how am I going to deal with them? If they have physical complaints, I'm going to be looking at dealing with those physical complaints and seeing, is there an underlying feature that could have an affective component? Many of our conditions like chronic headaches, back pain, neck pain, TMJ, many of our diffuse abdominal pains, the irritable bowel syndrome, our migraines, our patients that have interstitial cystitis and chronic pelvic pain. These all tend to have a significant affective component. And I ask these patients, what's going on in your life? And I find that many of them have some aspect of anxiety and depression underlying the physical complaints. So because they do not present directly saying, I'm depressed or have anxiety, you still do not overlook the underlying psychiatric symptoms that are often behind the physical complaints. Once you have the symptoms of anxiety and depression, in terms of symptoms, now you ask, do you worry about the future? Do you dwell in the past? And patients that say, I worry about the future, I now know that I'm heading toward an anxiety disorder. If they say, I really have problems with regrets in the past, and this is where my problems have existed, I'm thinking more of the depressive disorder. If it's anxiety disorder, I now start looking at which of the 5 anxiety disorders I'm dealing with. If it's generalized anxiety disorder, I know there's been general worry about most aspects of their life. Panic disorder, the panic reaction, social anxiety disorder, post-traumatic stress disorder, and OCD. Remember that obsessive-compulsive ruminant thinking often leads to generalized anxiety disorder. And all of the anxiety disorders untreated will also lead ultimately to depression. So it's important to tease out which is the primary condition. And remember that most anxiety disorders occur much earlier in life, usually during childhood and early adolescence, where the unipolar depression occurs in late adolescence to even more so mid to late 20s. If I know that they have dwelled in the past and have had a depressive disorder, I now go to the next step on my algorithm. I know it's depression and depressive disorder. I have to decide, is it bipolar or is it unipolar depression? If it's bipolar, and that's what I look for the mood lability. Does the depression come on suddenly? Are there rapid changes in mood versus over weeks to months? Are there multiple episodes? Have there been problems with jobs and relationships? Have there been problems with the court system, with DUIs? I look for the loaded family history, and I look for that early age of onset into the teenage years. When I see all of these factors, and they tend to run together, I now very quickly have the tentative diagnosis of bipolar disorder. And then I can divide that up to see, is it bipolar 1 or bipolar 2? Remember that the bipolar 2 are the typical patients that we're going to see in our practice. Bipolar 2 have that strip, that rhythm that continues to change from mild depression sometimes to significant depression to feeling good to having that good effect, that good time, and then paying the price. Bipolar 1 tends to be much more episodic. It may occur from childhood, but often seen in the adolescent years, and may have irritability and mania or hypomania long before the depression. So when you have a great deal of irritability in adolescence, without depression, it does not rule out a bipolar state. The other factor is that very often in bipolar 1, you will not have episodes of depression alternating with the mania, except every 2, 3, 4 years, unless you treat these patients incorrectly and start a rapid cycling or switching from depression to mania with the use of antidepressant medications. Primarily the older tricyclics, but in addition, our current SSRIs and SNRIs will also do that. And once you destabilize the mood of a bipolar patient, whether it be bipolar 1 or 2, you start creating havoc in the mood lability and the increasing difficulty and the mixed states. So that's why the focus on appropriate diagnosis and treatment is so critical. And finally, once you have that patient who you think has bipolar disorder, you also want to say to yourself, could there be ADHD? Is there a family history to suggest that ADHD is coexistent with bipolar disorder? Or perhaps this patient in effect really has ADHD and not bipolar, based on time frame, age, and other issues. So remember, bipolar disorder has mood lability and ADHD has a cognitive disability. The issue is sometimes we get on track to make a diagnosis of ADHD or bipolar disorder because these are seductive diagnoses. It's easy to look at patients that have mood disorders, lability, substance abuse, and say, you have ADHD, you have bipolar. However, I want you, as a final thought, look in the other direction. I see patients who come in with a diagnosis of ADHD and or bipolar, and in fact they have an anxiety disorder and they are not responding to the usual medications that we use for bipolar disorder. And I go back to the algorithm, to step 1, and I say, is this an anxiety disorder or is this a depressive disorder? And it's not unusual that in the patients that do not have bipolar disorder, what do I find? I find an underlying PTSD or OCD that was not recognized. And now I back up and go to step 1 and start heading in a different direction. And I start treating the anxiety disorders as a primary condition. You see, this algorithm can work in either direction, forward or backwards. The goal is you need some structure, because when you start looking at this psychiatric patient who has 5 or 10 different psychiatric and physical complaints and social problems and financial difficulties, it's easy to lose the foundation. Once you know you can drop back and you have these basic 4 decision points, then you are now set to set the foundation at whatever age, later childhood, adolescence, adults, to have a foundation on which you can build the rest of the psychiatric history that leads you to a focused diagnosis and then focused treatment. So with that, I thank you for your time and your attention. I feel that we've covered this subject as well as I can in 1 hour. There are other areas that might be of interest to some of you in terms of dealing with the anxiety disorders in more detail. Also, the treatment of bipolar disorder could easily be an hour or 2 in discussion as well, and I have led these types of discussions and types of treatment, and I would be glad to. If you are interested, please feel free to contact the university. You also have my email address here. And right now, since there are no questions, again, I will thank you for your time and interest. It's been not only my pleasure, but my honor to be able to speak to all of you. Thank you.